I'd like to welcome all of you to the first in a series of 6 educational webinars that we are putting on by the Epilepsy Association of Western and Central Pennsylvania. I am Francine Eden, the Adult Services Coordinator at the EAWCP, and I will be your host tonight. I would like to thank our sponsors for their support. We have Greenwich Biosciences, ASI, LivaNova, SK Life Sciences, and Zogenex. I'm going to introduce our speakers. We have 3 wonderful speakers, and they're setting up their presentation right now. We have Danielle Corson, Hallie Gilbert, and Alexus Widmer. Danielle is an expert physician assistant with UPMC University of Pittsburgh Department of Neurology Surgery. She joined the department in 2011. Ms. Corson received her undergraduate education at the University of Pittsburgh and a master's degree in I just saw her just now, so I got thrown off, Danielle. A master's degree in physician assistant studies from Salus University in 2011. And she's an adjunct professor at the University of Pittsburgh Physician Assistant Studies Program and a preceptor of PA students from 3 universities. She has been working in the Epilepsy and Movement Disorders Surgery Program for more than 8 years. Her clinical specialization includes epilepsy surgery, deep brain stimulation for movement disorders and obsessive compulsive disorder, and intraoperative language and motor mapping for surgeries in eloquent cortex. She also has a particular interest in the programming of neurostimulation devices such as the DBS and RNS. She is board certified by the National Commission for Certification of Physician Assistants. Hallie Gilbert is a physician assistant from West Newton, Pennsylvania, who graduated from Seton Hill University in 2018. She has been working with the UPMC Comprehensive Epilepsy Center for the past 2 years. And Alexus Widmer is originally from Rochester, Pennsylvania. She went to Duquesne University's Physician Assistant Program and has been an epilepsy PA for the past 2.5 years with the University of Pittsburgh Comprehensive Epilepsy Center and works primarily in the epilepsy monitoring unit as well as the outpatient epilepsy clinic. And thank you all for your patience. I think we're ready to begin, if that's okay with my speakers.
That works for us.
Can everybody see the PowerPoint?
I believe we can all see the PowerPoint, yes.
Thank you, Francine, and the Epilepsy Association for inviting us to speak with you today. And I think we're ready to get started.
So, like Francine said, my name's Hallie. I'm one of the physician assistants who works at the Epilepsy Center, and I'm going to get us started tonight. So first of all, I'd like to thank everybody who's tuning in from home, as well as Francine and the Epilepsy Association for inviting us to speak. We're really excited to be here. So I primarily work in the outpatient epilepsy center. So I'm going to talk about initial neurology appointments and follow-up appointments and what to expect. So what should you do before your appointment? Some people think that you need a referral in order to see an epileptologist, which is just a fancy word for an epilepsy specialist. You don't need a referral in order to see an epilepsy specialist. Your existing neurologist or your primary care doctor could refer you, or you can simply call and make an appointment yourself. Prior to your first appointment, what should you do? If you have a neurologist already, the most important thing you can do is have your previous medical records sent to the office ahead of time. It's always helpful for your doctor to review any past medical records before your appointment. So it's a good idea to call your existing neurologist a few weeks in advance to make sure that your records arrive in time. If you have any records at home, if you have any imaging, maybe on a CD, or any documentation like papers from a hospital visit, you should bring those with you as well. If you keep a list of your medications, you should bring that to your appointment. Or if you don't have a list of medications, you can just simply bring the medication bottles themselves. If possible, plan to bring someone with you, a friend or family member, who has witnessed seizures and can help you describe them. I know that this is difficult to bring people to appointments right now with COVID-19, but most doctors' offices are allowing you to bring at least one person with you to each appointment. Lastly, if you keep a seizure calendar, it's really helpful to bring that with you. Or if you use an app to keep track of your seizures or medications, it's helpful to bring a charged smartphone or tablet. That way you can access that information during your appointment. So at your initial appointment, the most important thing that you're going to talk about is a detailed seizure history. So I'm going to actually jump to the next slide to talk about that. So this here are examples of questions that you'll likely be asked regarding your seizures. And this is why I say it's helpful to bring someone with you who has witnessed a seizure, because most people don't know what happens during their seizures. So your doctor will probably start off by asking you, when did seizures first start? And it's okay if you don't know exactly what year or exactly what age seizures started. A general estimate can still be helpful. If they started in early childhood versus starting in late adulthood, that makes a difference to the doctor. So any information you can give us about when they started is helpful. Another question we often ask is, do you get a warning sign or an aura before your seizures? A lot of people tell me that they get a feeling that's really hard to explain. They do feel something, but they don't know how to explain it to me. So it's helpful if you can try to think about that feeling beforehand and think about how you would explain it to someone. They're going to ask you what happens during the seizure itself. With this question, that's when it's especially helpful to bring a friend or family member with you, because most people don't know what happens. If anyone has ever been able to take a video of a seizure before, it's helpful to bring that with you on your phone or tablet if possible. They'll also ask, how long does the seizure last? How long does the seizure last? And how do you feel after the seizure ends? They'll most likely ask how often seizures are occurring. This is a very important question. So this is when it comes in handy to bring your seizure calendar with you so that you're able to answer that question. They might ask if anything triggers or brings on your seizures. For some people, this may be stress or sleep deprivation. For other people, they may never know what triggers their seizures. Then they'll most likely ask you the date of your most recent seizure as well. So again, bringing that seizure calendar is very important. So Danielle, if you can take us back to the last slide. So those are some example questions of what you can expect to be asked about your seizures. So be prepared to answer those questions about what happens before, during, and after seizures. In addition to that, your neurologist will likely ask you about your other past medical, surgical, and family history, even about conditions that aren't related to your epilepsy. So be prepared to talk about those as well. You can expect a comprehensive neurologic exam during your appointment. Your doctor might ask you to do some funny things. They might ask you to do funny things with your hands or to touch your nose. That's all giving them good information. So it might seem a little strange, but they'll ask you to do a series of commands. Your appointment will likely end with a discussion about further testing or medications. So if this is your first ever visit to a neurologist, you'll likely have a few tests to complete afterwards. If you've already seen a neurologist in the past, your old testing that you have may be sufficient. If you're already on a seizure medication, your doctor will likely confirm in the pharmacy with you and then make sure you have refills on your medication. If you're not on a seizure medication, your doctor may look at the past medical history and everything you just discussed and give you some options of seizure medication that would be good for you to start based on your past medical history. So that covers initial appointments and what to do leading up to those appointments. So now I'm going to discuss follow-up appointments. So with follow-up appointments, you might see your original neurologist or epileptologist, or you may see one of their colleagues, like a physician assistant or a nurse practitioner. So the most important question you're going to be asked at your follow-up appointment is, how many seizures have you had since last visit? Again, this is why it's so important to keep a seizure calendar. This question allows us to track how well the medication changes we made at the previous visit are working. So, when we're talking about those medications, your doctor will also ask if you're experiencing any side effects with your medications or having any problems with your medications. It's always important to be honest about this so that we can help you find the best medication that works for you. Lastly, they'll discuss any testing that you had completed between your first appointment and this appointment, and discuss any diagnostic imaging or testing that may have been done. So next, I think Alexus is going to talk about some of that testing.
Hi, thanks, Hallie. I'm Alexus, as Hallie had mentioned. I'm also one of the physician assistants that works, as Francine mentioned, in the epilepsy monitoring unit as well as the outpatient clinics. And some of the testing that may be ordered may include an EEG, and what this stands for is an electroencephalogram. A lot of patients wonder what this actually does, and the answer is that it records the electrical activity ongoing in the brain. There are specific patterns that our epileptologists look for that can show abnormalities or abnormal activity, which may indicate seizures or seizure tendency, which essentially means that they are at risk for epileptic seizures. The actual test itself involves placing electrodes on the scalp, and these are placed in such a pattern that is a standardized way across hospitals that is a specific measurement for where these electrodes go so that everybody is recording from the same areas on a person's head. If you can imagine, everybody's head size is a little bit different. It's important that they're coming from the same places that it should. So an EEG technologist will place these electrodes and secure them to your scalp. And these are connected to wires, and these wires are connected to a box that do the recording of the electrical activity. In preparation for something like an EEG, your hair should be clean and dry. No hairsprays, gels, or other hair care products, as it makes it difficult for those electrodes to stick on the scalp. And the important thing to mention, especially with EEGs, regardless of how long these EEGs are, is that if there are no symptoms captured during the EEG, it does not necessarily rule out epilepsy. There may be abnormalities on there that suggest that a person is prone to epileptic seizures, but even if it's normal, it does not mean that somebody does not have epilepsy if they did not experience their symptoms during the recording. These can also be done in the inpatient setting, outpatient setting, and it can include our epilepsy monitoring unit as well, which we'll get to a little bit later. So our first is our routine EEG. This usually records for less than an hour, and this gives our epileptologist a brief kind of snapshot of the brain's electrical activity. This can be ordered at the very beginning of your evaluation, such as the initial appointment in the outpatient clinic, or it can be ordered periodically, over the course of time if things start to change, or if patients are experiencing new symptoms or something concerning. The techs, when they place the EEG on the patient's head, they may ask them to perform certain tasks. They may ask you to say different things. And this is all kind of assessing the way the electrical activity looks when somebody is doing these things. Because it is electrical activity and the electrodes are on the scalp, it does pick up muscle artifact, especially from your jaw here. So you can see when you chew, you can see when you blink your eyes, they all make certain patterns in the EEG. So these are things that our techs ask you to do while they're doing their baseline procedures so that we know what it looks like going forward. And sometimes, depending on where you're at in your evaluation, a provider may ask you to sleep less hours the night before an EEG and to make this what we call a sleep-deprived EEG, as some abnormalities are more common in sleep or may only present in sleep with certain types of epilepsy. The next type of EEG is an ambulatory EEG, and this allows for prolonged recording. Typically, these run for 24 to 72 hours. And the nice thing about these EEGs are that a patient will present to a center to have the electrodes placed on their head, and then they'll be sent home to wear the EEG during their normal activities at home so that they're in their everyday level of stress, their everyday home situation, and then they aren't required to come back for a day or a few days later, and that's when the EEG is taken off. As we already talked about, that advantage of recording in the person's home. We'll get to the epilepsy monitoring unit next, but that can be a little bit of a different environment. One of the disadvantages, however, of an ambulatory EEG is that the longer this records, the longer the patient has these electrodes on their head, the poorer the quality it can become, because if you can imagine electrodes stuck to your scalp, they can become a little bit loose in sleep or as you're doing certain things, and there's nobody there really to fix them until they're taking those electrodes off. An important, extremely important part of the ambulatory EEG is the event button. This is a button that's attached to the EEG itself, comes on a wire, normally has a small handle, and patients can press this button when they experience any of their ARAs or any of their warning symptoms prior to a seizure. If they feel like they are experiencing a seizure or after a seizure, and if they're around a family member or a friend who's witnessed symptoms that the patient may not be aware of, they can press it as well. And what pressing the event button actually does is timestamp it. So when our epileptologists are reviewing these records, they see exactly when that button was pressed, and they can look exactly around that time to see if there's any of those abnormalities that we talked about ongoing at the time a patient experiences these symptoms or somebody was concerned that something was happening. I also wanted to mention something not everybody thinks about when they're wearing an ambulatory EEG is that you can't chew gum. As we talked about, some of those marks that the EEG indicates when somebody is chewing or their jaw is moving. Chewing gum creates an artifact and it kind of makes the EEG extremely hard to read. So that's always an important thing to consider as well. All right, moving on to the fun stuff is what I call it, the epilepsy monitoring unit. We call it the EMU for short. And this is considered the gold standard test for classifying symptoms that are concerning for seizures. What the epilepsy monitoring unit involves is an admission to the hospital in a diagnostic unit with around-the-clock monitoring of both electrical activity in your brain with the EEG, as well as with video footage for what we call electroclinical correlation. And what that means is that there's simultaneous EEG abnormalities ongoing with symptoms, then we can call this an epileptic seizure. If there's no abnormalities ongoing when a patient is experiencing their symptoms, then there's no electroclinical correlation, and we can say these symptoms are not related to epileptic seizures. We get patients admitted to our unit all the time for various reasons, and some of those common reasons are listed there on the slide. Classification of spells or seizures. Patients may present to their outpatient office and say they're having these symptoms, and they talk them over with their neurologist or their epileptologist. And if there's anything concerning about these symptoms that we feel we need to classify a little bit better, there are those other EEG options, such as the routine EEG, the ambulatory EEG. But if we really want to make the best of classifying these symptoms with video footage to see exactly what patients are experiencing, they get referred to the epilepsy monitoring unit. Sometimes patients are on medications and they're still experiencing some symptoms that are concerning for seizures, and therefore they get admitted to determine how frequent their seizures are even on medications, because this unfortunately can happen. The third reason there is localizing where seizures originate in the brain to evaluate a patient for the possibility of epilepsy surgery, which Danielle will talk about a little bit as well. And then a final reason there is to safely change anti-seizure medications. Sometimes patients may have side effects of a medication, but they're doing really well in terms of their seizures and are afraid to transition onto a different medication in the outpatient setting. And sometimes we can admit them then to the unit and change them in a safe way so that we're monitoring the electrical activity while we're changing medications. And if need be, we can give them rescue medications kind of in advance if we feel that their EEG is a little active or showing that they have a higher tendency to have seizures. Sometimes a common misconception about the EMU is that somebody is referred to that unit to fix their seizures. And unfortunately, although we wish that were true, it is a diagnostic unit. So this is used as a fact-finding mission, as one of our epileptologists likes to tell patients. It's there to identify symptoms as epileptic or not, and kind of as a test moving forward that will help your doctor figure out how to treat these symptoms, how to best treat these symptoms, and where their course of treatment may lead. To prepare for the EMU, on the next slide there, we generally tell patients that our admissions typically last 3 to 7 days, but each patient is a little bit different. If you can imagine all those other reasons why a patient can be referred, each of those missions can take a little bit of a different amount of time. So we tell patients for the best chance at maximizing their admission. It's ideal, I should say, if patients can clear their schedule for that time period, if possible, to best give their admission a chance to solve that mission or fulfill that mission. Obviously, in the real world, we know sometimes this isn't possible and we work with what we get. But ideally, we have that free time. Also, in preparation for the epilepsy monitoring unit, patients will say, you know, they're going to take me off my seizure medications anyway to help things happen. And while that may be true, they should still take their medications the morning of, unless otherwise directed by their healthcare provider. An up-to-date medication list is also extremely important, as Hallie mentioned, with your outpatient appointments, as well as inpatient, because sometimes things change in between and nobody wants to give a patient the wrong dose of any kind of medication. So to help everybody in the hospital and to help yourself, it's always best to carry an updated medication list. And then during the admission itself, there are some procedures that we generally follow just as kind of a standard protocol. So every patient will get an IV. There may be routine blood work as well as seizure medication levels drawn. An EKG is always done because sometimes symptoms that are concerning for seizures are actually heart related. And then there's also the possibility of reducing or withholding seizure medications to help events happen. This isn't necessarily inducing a seizure. Nothing is given to a patient to make a seizure happen. But by reducing medications, this may make the situation a little bit more likely. All right, let's go down here. And then Danielle will take over here for some of those other tests.
So as part of your initial evaluation, when you are present with seizures for the first time or diagnosed with epilepsy, we often order an MRI of the brain. So an MRI uses a magnetic field to create a very detailed picture of the brain itself. And we're looking to detect possibly some structural abnormalities of the brain that can cause seizures. And some of these abnormalities may be something that you were born with and the way that your brain developed. And some of those abnormalities could be acquired throughout your life. Things such as tumors, strokes, or other brain injuries can cause seizures. So an MRI, it's non-invasive, it's painless, and it does not expose you to any radiation. We do have to sometimes place an IV if we need to give contrast dye for the study, although that's not always necessary for epilepsy. If you need to get contrast for the MRI, you may have to have some blood work done prior to the MRI to check your kidney function. And you'll be instructed to arrive about 30 minutes prior to the MRI, and you'll need to remove all metal from your body. So the MRI machine is a large magnet, so you need to remove your clothing or jewelry, anything that has metal in it. And it's important to note that not all MRIs are the same. So an MRI is a magnet, and the stronger the magnet, the more clear picture we get of the brain. Things such as open MRIs don't provide as good quality pictures as some other MRIs. And at our epilepsy center, we have like a high definition MRI. It's a very strong magnet that gives a really great detail of the detailed picture of the brain. And also, coming to an epilepsy center, there are certain protocols we do with MRI that show areas of the brain that are likely to cause seizures. It gives a more detailed picture of those areas as well. And here is some examples of MRIs for people who have epilepsy. On the left, you can see an area of what we call dysplasia. So it's the way this person's brain developed when they were a baby. Some cells didn't migrate to the right areas of the brain. So you can see those large chunks of of gray matter in the areas where there should be white matter. And the next picture here, you can see a picture of hippocampal sclerosis, or sometimes called MTS, which is a scar in the brain. There is also a picture here of someone who has a tumor, and then over here, someone who had a brain injury and caused some scar tissue here.
Sorry, I muted myself. The next test we have here is the magnetoencephalogram MEG or MEG. This is also a non-invasive diagnostic tool. And we use this in conjunction with an EEG and primarily for patients undergoing an evaluation for epilepsy surgery. So this typically is not involved in your everyday outpatient clinic or outpatient testing for a patient with epilepsy. We typically do reserve it when we do a pre-surgical evaluation. Well, what the magnetoencephalogram does is it maps the magnetic fields produced by the brain's electrical activity, and this helps us localize where seizures are coming from. We use all of these tests kind of in conjunction with each other to provide evidence of where seizures are localized. But we can also use this to map some regions of the brain that are responsible for important functions like language or motor or movement. And this tells our epilepsy neurosurgeon that this is the region of the brain responsible for these things, and that's not a region that could be taken out. It's too important, obviously. So something also about the MEG is it does take normally a few hours to complete. But preparation overall is similar to an EEG because they do place electrodes again on the scalp. And typically when a patient does the MEG, they sit in a large room with magnetic sensors. So it is also ideal for patients who are claustrophobic because there is no small machine that they have to sit in. It is quite large and it doesn't make any loud sounds like an MRI might. But as a MEG, with the word magnet in it, uses a magnet. Some patients with devices that can be altered by magnets, such as certain programmable shunt valves, they may not be able to do this because the magnet may change their settings. So just as a kind of a side note about the MEG. And there on the next slide is an example of a MEG combined with an MRI image. So the MEG itself will localize that abnormality with the electrical activity in the brain and the abnormal magnetic current there. But then this information is combined with an MRI to kind of show visually where these abnormalities are. And then that therefore translates as to where the seizures may begin.
Another test that you may be asked to have is neuropsychological testing. And this is testing that shows how seizures affect the way a person with epilepsy thinks and remembers. So this testing examines functions of the brain such as language, memory, and attention. And if you have difficulty in one of these areas or with certain tasks, it may indicate where the seizures are coming from in the brain. So for example, people with seizures coming from their temporal lobe often have difficulty on tasks related to memory. This repeat testing over time may show some changes as well. So if you've been tested in the past and you may repeat it at some point in the future, and we can assess overall how epilepsy is affecting the way that you think over time. This test can take a couple hours, maybe 4 hours. Some tests done here may be timed. Some tests will be easy and some will be hard. And some examples of testing that might be done, you might be asked to write or draw. There'll be some language tasks involving talking, and they may ask you to remember things as well throughout the test. And there is no passing or failing this test. And the goal is just to get an idea of how you're doing right now. And a lot of factors are considered for this, such as your age, your educational background, and we're comparing your test results to others of a similar background to you. And this can be helpful during an evaluation for surgery. It helps establish a good preoperative baseline, and that can help predict any potential cognitive impact that surgery might have on you. We can do a baseline prior to surgery and then repeat it after surgery to assess for any changes. And doing so could help us identify some problem areas that might direct us to order some therapy, some speech therapy or cognitive rehab if needed. Some additional tests that might be ordered include a PET scan and a SPECT. Both of these are imaging studies. They're done through nuclear medicine. So we're looking at either metabolism of the brain or blood flow in the brain. And these can aid in determining where the seizures might be coming from. So for these tests, a radioactive but safe dye is injected into a vein. And then we do some imaging, either a CT scan or an MRI. And a PET scan is looking for areas of decreased metabolism in the brain. So this is something that's done in the interictal state, which means when someone is not having a seizure. And what we might see on a PET scan is a dark spot, which might indicate that's where the seizures, that part of the brain is impacted by seizures. A SPECT scan can be done actually during a seizure. So while we have a patient admitted in the epilepsy monitoring unit, when they begin to have a seizure, we can inject this dye at that time. And what we'll see is during a seizure, the area of the brain where the seizure is starting has increased blood flow. So we'll see an increase in this dye uptake in that area of the brain. For these studies, IV access is required to inject the dye, and there may be some restrictions on eating and drinking prior to the scan because we're looking at metabolism here. So here are some pictures of a PET on the left and an ictal SPECT. So this was the image on the right was taken during a seizure. So you can see this PET scan here. This area here is nice and bright on the left side, and you can see the corresponding area on the other side is darker. So that's an area of decreased metabolism in the brain. And similar over here with the SPECT, you can see an area of brightness on this side compared to this side. So that's suggestive where the seizures might be coming from. If medications fail to stop your seizures, surgery might be an option. So your epileptologist will order a comprehensive evaluation, so including many or all of the studies that we just talked about. And once those tests are completed, all of the results will be discussed at our patient management conference. So this is a group of doctors get together. This includes neurologists, neurosurgeons, radiologists, and neuropsychologists, and we all get together and have a meeting where we discuss the results of all your testing. And we come up with a recommendation as a group if you're a good candidate for surgery and what that surgery might be involved, what that surgery might involve. So once that's done, if surgery is recommended, you'll be scheduled for an appointment with a neurosurgeon to discuss the surgery. So it's important to keep in mind that coming for a consultation with a neurosurgeon does not mean that you have to have surgery. There's no obligation. But the goal of that appointment is to meet with the surgeon so we can explain the type of surgery that's recommended for you, explain what's involved, address any questions or concerns you may have, and give you all of the information you need to make the decision about what's best for you. So in general, this appointment could take 30 or 45 minutes, however long it takes to answer the questions that you may have. And it's helpful if you bring a friend or family member with you for support, but also to help you ask appropriate questions and remember the discussion that takes place during your visit. So we'd like to thank everybody for joining. And again, thank you to the Epilepsy Association for inviting us to talk. And if you have any questions, we'll take them at this time.
A few people wrote in questions with their registration. And also, if any of you have any questions now, you can write them into the chat and we'll take them. What are the restrictions in driving age if you are tolerating your anti-seizure meds?
Well, that's a question that will be addressed in most of your outpatient appointments, be it your first appointment or a follow-up appointment. If you live in the state of Pennsylvania, the law is 6 months of seizure freedom. So once you hit the 6-month seizure-free mark, the PennDOT or the Pennsylvania Transportation Department will send you some paperwork. Once your neurologist or epileptologist fills out that paperwork and you receive the license from PennDOT, as long as you've been 6 months seizure-free, you're legally able to drive.
Please discuss seizures that only occur during sleep cycles and research on prevention for these types.
Well, we do have some patients that have a certain type of frontal epilepsy, meaning seizures originate from the frontal lobes. And some of these seizures strictly have a nocturnal pattern or nighttime pattern. So they may go their whole lives never having a daytime seizure, and it's specific to the abnormalities that occur in the electrical activity only at night or in sleep. As far as research goes, I am not too up to date on where they stand as far as prevention, but typically some of those seizures may be a little bit harder to control, as frontal epilepsies can be. But you know, there is always there are multiple medications, which I'm sure will also be addressed in another webinar. And some medications tend to work better for frontal lobe epilepsies.
And what is the best center for epilepsy in Pennsylvania?
I think we're a little biased on that one.
I think we're really lucky in Pittsburgh. We've got 2 great centers, both at UPMC and at Allegheny General. So I think everybody will be happy with either one. So I came in there and I guess I answered that one.
Thank you.
Cognitive impairment, what can we expect over time?
So like
And
Danielle,
if some of these questions, I would ask all these questions, they may not pertain to the subject matter that actually we were talking about today. So I will definitely hold on to them if, you know, and we can ask them at one of our other meetings too. But if one of you wanted to talk about that, if I interrupted you.
oh, I think like Danielle mentioned, you know, it somewhat depends on where seizures are stemming from in the brain. One of the big things that Danielle mentioned is temporal lobe epilepsy, which is one of the most common types of focal epilepsy. The temporal lobes do house some of the brain's memory centers. So some patients with those type of epilepsies, if they have frequent seizures, they may experience a little bit of a decline in memory. But typically, once you get seizures under control, that memory does tend to rebound.
I see we have someone that asked a question in the chat. When a seizure is captured while at a routine EEG, would an EMU stay with med weaning still be needed?
Not necessarily. If we have our answer with that routine EEG or however it's done outpatient, a short EEG, there may not be an epilepsy monitoring unit stay necessary. And we don't always refer every single patient to the epilepsy monitoring unit, especially if we are able to pretty much have our answer otherwise. Epilepsy is a clinical diagnosis, which means if there is a story fitting of epilepsy or concerning for seizures and there are certain risk factors present, you know, we can make that diagnosis of epilepsy without these tests. But sometimes these tests are needed more so to confirm things. So that EEG confirmed that seizure, and it may also then confirm the type of seizure that it was. So an epilepsy monitoring unit stay is not always necessary if we have our answers through other modalities.
Thank you. And I want to thank all of our speakers tonight, Danielle Corson, Alexus Widmer, and Hallie Gilbert, for a very informative presentation. Thank you very much, and thank you for giving your time too.